Well, hello everybody, and welcome to today's webinar sponsored by HeartFlow. And on behalf of HeartFlow, I'm happy you've joined us today with SCCT to bring exciting information to you about building the evidence behind HeartFlow Plaque Analysis. My name is Dr. Alan Taylor. I'm the chairman of cardiology at MedStar Heart and Vascular Institute in Washington, D.C., and also a professor of medicine at Georgetown University. I'm a founder of SCCT, and I was the inaugural editor of the JCCT. And today it's my deep pleasure to moderate today's session with our two expert speakers, Dr. Michael Morris and Dr. Christian Madsden, who I'm going to introduce in more detail as their talks come up. But as we go to the next slide, I wanted to basically bring you the take-home messages and establish our intentions, and then we'll dive right in with Christian's first talk. So take-home messages today really follow from our intentions. The intention of being with you today is to, first to really build your confidence and to inform you about the application of AI-assisted coronary plaque analysis as a clinical tool ready to begin use to drive patient care decisions. And in building that confidence, to bring you the most recent evidence just presented at ESC, the extension, the 7-year extension follow-up of the advanced DK study, and then from SCCT in July, the results from the DECIDE Registry, an exciting registry showing the clinical impact of AI-assisted coronary plaque analysis. So our take-home messages for you to establish those intentions are these. The use of AI-assisted coronary plaque analysis, along with FFRCT, a well-established tool, improves risk stratification and prognosis in stable angina. The clinical implications are that this AI-driven plaque analysis supports a more precise, proactive, and personalized cardiovascular care, and you'll see its impact on up to 2 out of 3 patients that we care for today through the DECIDE registry. This analysis provides accurate and reproducible plaque quantitation and is validated against IVUS. That's building your confidence and understanding. And really, it's the idea of driving patient care outcomes and clinical decision-making. And this early evidence-based detection matters as we shift from a risk-based model of coronary disease to a disease-based model. And that's an important transition that this coronary plaque analysis is driving. And then we'll show you how the DECIDE registry, really exciting new data, is driving meaningful changes in management that'll impact your care. So with those take-home messages, and we'll come back to them at the end, it gives me pleasure with the next slide to bring your first speaker, who is Dr. Christian Madsden. Christian is a researcher from is a Danish physician and cardiovascular researcher who is affiliated with the University Hospital in southern Denmark. He completed his PhD in cardiology, and he focuses in that on the use of artificial intelligence to enhance diagnostic precision and treatment planning for patients with coronary artery disease. A really great background to bring this topic to you today. His work centers on FFRCT analysis and advanced AI-driven simulation that evaluates blood flow in the heart's coronary arteries using CT imaging. He's contributed to multiple peer-reviewed publications and presentations, and has given his findings at international conferences, helping position Denmark at the forefront of AI-assisted cardiovascular medicine. So thank you for joining us, Christian, and we look forward to your comments today. Thank you so much.
Well, thank you for that very nice introduction, Alan. So with that in mind, I guess from here on and now, I can only disappoint. Anyway, my talk today is going to be a little bit about the prognostic value of performing coronary plaque analysis and FFRCT, and what we've learned about this from the advanced DK trial. So throughout my career, whenever I've been writing up manuscripts, my supervisors has always kept telling me to keep it simple. And that's good advice. And in terms of risk in patients with stable angina or stable coronary artery disease, CAC scoring is the most simple, the most basic approach, because we know that with increasing calcium scores, we see an increase in event rate. We know that the calcium score predicts risk regardless of whether the patient has obstructive coronary artery disease or non-obstructive coronary artery disease. So it's a good marker of risk. However, it's also a crude marker because it does not provide you with any information on the composition of the plaques which the patients have. And also, as we've learned from the paradigm trial, whenever patient starts to be on statins and the plaque starts to heal, we see a transition from non-calcified plaque and into calcified plaque. So thus, an increase in the calcium score may also be a sign of healing of the plaques. Secondly, you do not gain any information on whether or not the patient may benefit from revascularization. And I know that this might be a little bit controversial, but this is my personal point of view, because I believe that what we saw from the FAME2 trial was actually a positive trial demonstrating that you can reduce the risk of spontaneous MIs if you perform revascularization in accordance with physiology. And this is stated by the supplementum table. And also it's worth keeping in mind that they found these results despite having an underpowered study in which they only included half of the amount of intended patients, and also having a significant crossover of around 51% in the medical arm who underwent revascularization. So pretty powerful indeed. So let's try to keep it a little less simple than just the calcium score. And by doing that, we can integrate plaque analysis and FFRCT. And this was exactly what we wanted to assess in the advanced DK. And what is the advanced DK? Well, it's an observational 7-year follow-up study of 900 symptomatic patients. It's really important to know that these are the everyday patients that we see in the clinic. So these are patients that came to us, they had symptoms suggestive of new onset stable angina. We did a CT scan, they had coronary artery disease with at least one stenosis of more than 30%. We sent them to an FFRCT evaluation, and they were included in the study. In Denmark, we have access to great registry data, so we had information on the calcium score for all patients. We had information on all of the coronary revascularization procedures, and also on the medical treatment of all patients up until 3 years. So the way we categorized our patients in the advanced DK in terms of FFRCT was that we used the recommended approach of using the FFRCT value 2 centimeter distal to the stenosis, and if it was 0.80 or below, the patient had an abnormal FFRCT. If not, it was normal. In terms of AI-CPA, which is the artificial enabled coronary plaque analysis tool, we chose to go with plaque burden. And I'll come back to this a little later, why we chose burden instead of volume. But we wanted to assess risk. And when you want to assess risk, I really like to dichotomize the data. And how do you dichotomize plaque? Does it even make sense? Maybe not. But if you want to try to dichotomize plaque, you need to have a cutoff value. And this is not established yet. This is still a new tool, and there's a lot of publications coming out. So we had to take on a pragmatic approach. And what we did was we just divided the population in two using the 50th centile. And this was with the intention to say that, okay, if there is an association between plaque, then the highest 50th centile should have an increased risk compared to the lowest 50th centile. The endpoint that we assessed across the 7-year follow-up was cardiovascular death or spontaneous MIs. And if we go to the results, so I started with CAC, and I'd also like to just start up by displaying the results for calcium scoring. I chose a dichotomous cutoff point of 400 for defining high calcium here. I know someone would say 300. It provides similar results. Now you know. But if we look to the calcium, what we find is the patients that have a high calcium score have an increased risk compared to patients with a low calcium score, a hazard ratio of almost 2.0. If we then look to total plaque burden and we look at the 2 centiles, what we see is an increased risk for patients with the highest amount of plaque compared to those with the lowest amount of plaque. Hazard ratio of almost 2.5. Okay, so the next question is, did we gain additional information by performing plaque analysis on top of the calcium score? So I did an adjusted analysis on the plaque results, and what we find is that no, we appear not to gain any additional information beyond calcium when we look at the total plaque burden. However, this is to be anticipated because total plaque burden comprises calcified plaque and non-calcified plaque. So when you're trying to adjust for calcium, which is part of total plaque burden, it will become incredibly difficult to actually make an adjusted analysis that will become statistically significant. So instead, I tried to look into the non-calcified plaque. And if we look at the non-calcified plaque burden and we then apply the decile for dichotomizing the patients once more, we find that, again, high non-calcified plaque burden associated with an increased risk compared to a low non-calcified plaque burden. If we then adjust the non-calcified plaque burden for CAC, what we find is this. All of a sudden now we have gained a significant amount of additional prognostic information on top of what we were able to obtain by assessing the calcium score. And it's important to say here that the adjustment was made for CAC as a continuous parameter and not a dichotomous parameter. So this is really exciting result and something that previously has been difficult to demonstrate in other papers. There's one paper from Circulation 2020 by Williams' group in which they looked into Scott heart and found a similar association for low attenuation plaque. But other than that, there's not a lot of data to suggest that performing a plaque analysis provides you with additional prognostic information. Okay, so this is a good thing. But what about the FFRCT? Can FFRCT be adjusted for non-calcified plaque then? And it would appear so. So if you have an abnormal compared to a normal FFRCT and you adjust it for the non-calcified plaque burden, you still get a significant difference, meaning that you gain additional information once more by performing the FFRCT on top of what you could obtain from the non-calcified plaque. But this is to be expected because if we look to the Emerald 1 and 2 studies, and these studies, they looked into patients that had ACS and had a prior CT scan, and they have created these models for predicting to see, could we have predicted patients that would suffer an MI beforehand? And what they find in both studies is that the highest amount of information gain was to be obtained by assessing the delta FFRCT value. That is the translesional pressure drop across the lesion. So our finding is in accordance with Emerald 1 and 2, and this just support our population. It is not just in our population that we see this. This has been demonstrated before in other studies as well. And then you might say, well, why perform plaque? Don't we just need to perform FFRCT? And that's a good question, and let us take a look at it. So the first thing I want to show you here is a graph for cardiovascular delta spontaneous MI. And the first curve I'm going to show you is the curve for patients who had abnormal FFRCT, but in whom either no revascularization was performed or the patient was only partially revascularized, meaning they had at least one vessel with abnormal FFRCT that was left non-revascularized. So they had residual focal disease. The second curve are for patients with abnormal FFRCT, in which all vessels with abnormal FFRCT underwent revascularization. So no, if performed successfully, no residual focal disease present. And what we see here is that patients that were incompletely revascularized had a significantly increased risk compared to those that were completely revascularized, further underpinning the importance of the delta FFRCT, the translesional pressure gradient, for determining prognosis. If we go to patients with normal FFRCT, we see that they have a similar risk compared to those that were completely revascularized. But that is not all, because if we look here around 3 years, we have almost no events present in the normal FFRCT group, and all of a sudden we start to see that they are accruing events at a rate that appears to be similar to what we are observing for the red line, which are patients that were incompletely revascularized. So what happens here? Well, one way to look at it to start with is by performing a landmark analysis. And basically what we've done here is we have split up the follow-up period into 2 periods. So we have the period from 0 years to 3 years, and we have the period beyond 3 years. And what you see for our 2 FFRCT abnormal groups, there is a similar risk from baseline and across time. But in the normal FFRCT, we see at the late onset of events, and they start to develop a significant risk as we progress beyond 3 years, with a hazard ratio of 6.26 compared to in the first 3 years. So now we asked ourselves, these patients were missed by the FFRCT analysis. The FFRCT analysis said these patients, they have a normal FFRCT, they have good prognosis. But could we have predicted this in some way by assessing their baseline plaque? So we took a look, and we looked at the baseline non-calcified plaque in patients selectively with normal FFRCT. And what we see initially is a clear tendency It's not statistically significant, but we see a statistic, an indication that patients with the highest non-calcified plaque burdens were at the highest risk. But here it's really important to remember that although we had a really high adherence to statins in our patient group, actually 24% of patients with a normal FFRCT were non-adherent to statins. And if you're not on statins, God knows what will happen with your plaques. Maybe you'll progress extremely fast. Maybe you'll have a plaque rupture. We don't know. So now we try to perform this analysis once more, but then only selectively in patients who were adherent to statins. And now we see this, a statistically significant increase in risk for patients with normal FFRCT who had a high non-calcified plaque burden compared to those with the lowest plaque burden. So a really clear and strong message here. So, and this brings me to my takeaway messages. And I say takeaway messages because this is an observational study. So this is not the ground truth. This is to peek into the data to get a sense of where should we be heading with the future studies. And the first thing that I feel that we can see from these data is that there is a lot of prognostic information that we can gain, which goes beyond the basic morphology of performing calcium scoring and assessing the degree of stenosis. And I think that CAC score is soon going to be something of the past, to be honest. I think that the coronary plaque analysis is going to take over. We have seen that both FFRCT and plaque analysis are required if you want a complete risk assessment of your patient. You have the FFRCT for identifying the patients that have an immediate risk of events if they have a focal lesion which is left non-revascularized. Then you have the plaque, which will help you to identify patients who have a late onset risk. We know that a high non-calcified plaque burden is associated with an increased risk if the patient is statin adherent and have a normal FFRCT. And I feel like this really supports the concept of staging your preventive medical therapy based on the coronary plaque analysis tool, so that patients with the highest plaque burdens should potentially have something additionally to statins. So not just statins, perhaps statins, PCSK9, something like that. And lastly, in terms of future studies, I think that we should try to do a study in which we look into patients with normal FFRCT, and we should do serial CT scans, 2 years, 3 years, to see if those patients that have high plaque burden, if their risk relates to them progressing towards abnormal physiology, or if there is something different going on in these patients. And lastly, I think that what we are still lacking are data on the lesional plaque composition and FFRCT to further try to enhance the risk prediction of these two tools. Thank you very much.
Yeah, thank you, Christian. That was wonderful. And congratulations on this work. Obviously just presented at ESC, so really hot off the press with this 7-year extension data from your study, the advanced DK study. And it really builds on what we know from Scott Hart, that it's not just about physiology, it is about disease, atherosclerosis disease that's detected through quantitative plaque analysis. And it's this HeartFlow platform now, which is the gold standard platform across the country in over 1,100 labs, not just providing FFRCT, but also now providing plaque analysis in a single platform. And so to bring us into that platform in a little more depth, again, our intention is to build confidence. And I want to welcome all 114 participants. Please feel free to put your questions in the Q&A during the meeting. We'll try to answer them in flow or get to them afterwards during discussion. But to build on that intention, we have now Dr. Michael Morris to go through the AI-assisted coronary plaque analysis in more detail and bring us to the clinical information from the recently presented DECIDE Registry data on how this impacts clinical decision-making. Michael is the Director of Advanced Cardiovascular Imaging at the Banner University Medical Center in Phoenix, Arizona. He completed his medical degree at Dartmouth, followed by radiology residency at Columbia and fellowship at the Mayo Clinic. He serves on the SCCT Advocacy Committee and the RSSNA Planning Committee for Cardiac Imaging. And he's a strong believer in the role of coronary CTA in the evaluation of coronary disease. and advocates for the pivotal role of FFRCT in further enhancing and advancing the value of coronary CTA. Michael, welcome, and thank you for joining us today.
Thanks very much, Dr. Taylor. And so we're going to, Dr. Matson did a wonderful job of really setting the table in terms of not only talking about the importance of plaque from an outcomes perspective, but also really reinforcing the distinct phenotypes now we're seeing of patients who have abnormal physiology versus those who have normal physiology but abnormal plaque volume and excessive atherosclerosis. And that's really where we're going to start with this conversation. And we'll start with an example, a patient of ours, 70-year-old gentleman, healthy, active guy, avid runner, some risk factors, hypertension, elevated lipids, has atherosclerosis, had a screening coronary calcium test, which demonstrated the presence of calcium, definitive demonstration of atherosclerosis. And yet the patient was hesitant to start lipid-lowering therapy, mainly because he's an avid runner, concerned about myositis, and just in general wasn't super excited about taking medications. And so decided to get more information, and so he was referred for a coronary CTA with quantitative plaque analysis. And these are the results from the anatomic perspective of his coronary CTA, the epicardial vessels, which demonstrate the presence of atherosclerotic disease in all three coronary arteries, as you can see by the calcified plaque, but importantly, non-obstructive disease. So he has atherosclerosis, but we know it's non-obstructive and by extension, no abnormal physiology. And then underwent quantitative plaque analysis. And these are the results of his quantitative plaque analysis. We know he has atherosclerosis, but you can see he's got a significantly elevated total plaque volume of 434 millimeters cubed. And importantly, a significant majority of that plaque is non-calcified plaque volume, really building on what Dr. Matson said in terms from a risk standpoint. But now you have this information, but the question is, now what am I supposed to do with it? Great, I know, the breakdown and the composition of his plaque, but like, how does that help me? What should I do? Well, of course, this is a conversation about AI quantitative plaque analysis. And so the first question is, can I believe these results? Dr. Matson did a really nice job of talking about the different types of plaque that we can assess, calcified, non-calcified, low attenuation. But, can I even believe the results? And these are the results I'm showing here from Reveal Plaque. Just over 250 patients from multiple sites, blinded prospective comparison of plaque volume versus core lab adjudicated IVUS. And the overall correlation coefficient between the quantitative plaque analysis and the IVUS over 90%. So demonstrating that you can really trust the results of the quantitative plaque analysis. And the next question is building again on what Dr. Matson said regarding this concept of plaque and outcomes. And he was showing how CAC scores are associated with increasing progressively worse outcomes. We have really nice observational data validating the role of AI quantitative plaque analysis with outcomes. On the left is paradigm data, again, showing that consecutive increases in plaque volumes are associated with outcomes. And on the right, data that was just recently presented by Tim Fairbairn, Jonathan Weimer-McCall, and others from the Fish and Chips Registry. This is UK population data. This is just from the Liverpool group, over 2,000 patients, demonstrating that as we break plaque down into different stages, as you can see here by red, green, and so forth, right, we see worsening outcomes. But importantly, these outcomes are controlled for conventional risk factors, age, gender, hypertension, hyperlipidemia, diabetes, but also stenosis severity and abnormal physiology with FFRCT. So even when you take into account these risk factors, especially stenosis severity and FFRCT, abnormal physiology, which are uniquely we derive from coronary CTA, we still see incremental prognostic implication in terms of increasing plaque volumes associated with increased likelihood of adverse outcomes. In this case, adverse outcomes were MACE and late revascularization, adverse outcomes were cardiovascular death and myocardial infarction. We can also see that same prognostic value when we subcategorize plaque into calcified, non-calcified, and low attenuation plaque, as I'm demonstrating here. This is observational data from ADVANCE, again, adjusted for age, traditional risk factors, diabetes, hyperlipidemia, stenosis severity, and abnormal physiology with FFRCT, again demonstrated incremental prognostic significance of these plaque subtypes relative to outcomes. In this case, MACE and late revascularization. Now, I've talked to you about different types of plaque, so we can see the total plaque volume that we get with the AI plaque analysis, or the subtypes of plaque: calcified, non-calcified, low attenuation plaque. So we're getting all this information. What are you supposed to do with it? Which number should you rely on to help make decisions, right? We have this barrage, a tsunami really of additional information. And how do I integrate it into practice? What should I do with it? Well, the first question is, which type of data has potentially the highest association with outcomes? And there is some variability, as Dr. Mattson mentioned. Is it non-calcified plaque? Is it total plaque volume? This is data that was validated from Scott Hart, demonstrating that the highest net reclassification index is seen when we use total plaque volume to predict outcomes, in this case, myocardial infarction. And so increasingly, you're going to see that total plaque volume as the metric used when we try and make decisions. And when we talk about making decisions, ultimately, that's really the crux of the matter here. Is now we have this data, we have the AI plaque analysis data, we have that total plaque volume data. What should we do with it? And this is observational data from DECIDE. 100 patients, 3 lipidologists were given the results of a coronary CTA and asked how they would treat a patient based on a staging approach. And that's really the unique thing, because now we can get quantitative results. We can be much more granular in terms of making decisions and how to treat patients. This staging paradigm, sort of like what we see with cancer, more aggressive stages or higher stages means more aggressive therapy. And the unique thing with DECIDE is that first we gave them the results of the coronary CTA, and then they were unblinded as to the results of the AI plaque analysis. And you can see a significant percentage of patients had their treatment plan altered based on the quantitative plaque analysis. Again, that additional quantitative information allowing us to be more granular in terms of treatment decision-making. But that's really just observational. The question is, how does that translate into practice? And that was really one of the key questions for the DECIDE registry. Multiple arms in the DECIDE registry. I'll focus on that second row, in which case patients had clinically indicated coronary CTA. The organ provider gets the results of that coronary CTA, in theory, makes some treatment decision based on the results. 90 days later, the referring provider is then given the results of the quantitative plaque analysis. And the question is, were there any management changes made based on the results of those quantitative plaque analysis over and above what happened just after the results of the coronary CTA? Now, the unique thing about the DECIDE registry is that it integrates in an algorithm to help our referring providers make a decision as to how to treat patients based on the plaque information, specifically 2 factors: the total plaque volume, as you can see in the second column, and then in addition, in the 4th column, using the percentile information, like Dr. Mattson mentioned, as a risk enhancer. So patients above the 50th percentile were considered to have a risk enhancer, and then were encouraged to be treated as a stage higher. So for example, if you had a patient whose total plaque volume was 150, which puts them in the moderate range, but the percentile was above 50 percentile, so let's say they're at 65th percentile, we would then treat them in the severe, we would then place them in the severe category. Now, importantly, in DECIDE, we did not mandate using this algorithm. Providers were free to treat patients in the best way that they thought possible based on their clinical judgment. But this was provided as a supplemental tool, and providers were encouraged to utilize this, again, using this staging approach. And what were the results? And this is the information that Dr. Taylor just mentioned, was just recently presented hot off the press at SCCT. What were the implications of providing the quantitative plaque analysis? What was the clinical impact? And you see here, just over 50% of patients had a management change when the referring providers were given the results of the quantitative plaque analysis over and above whatever change they might have implemented from the coronary CTA. So significant impact in terms of changing management. Just over 1/3 of patients had an escalation in treatment, either from an addition or intensification of, mostly from an addition or intensification of lipid-lowering therapy. And these changes were seen regardless of baseline characteristics of patients' age, gender, severity of stenosis, et cetera, right? So really demonstrating that it's the quantitative plaque analysis information that's really driving providers to make treatment changes. And this is what we want to see, right? The more abnormal your plaque volume is, the greater the stage, the more severe disease you have, the more likely you are to have a change in management, right? Just using this same cancer paradigm, right? The worse the stage, the more intensive the therapy. And that's really what we're seeing here. The worse the stage in terms of plaque, the more likely you were to have a change in management. And what were the results of those management changes? Well, just from a very sort of 30,000-foot perspective, right, we can see that the patients who had a change or intensification in their management were more likely statistically to have a significant reduction in their LDL. Now, this is a very crude measurement, right, because we know there'll be differences in LDL changes, let's say from a statin versus a PCSK9 inhibitor, but overall, right, significant reductions in LDL and cholesterol, especially the high-risk cholesterol in patients who received management changes based on the results of their quantitative plaque analysis. So let's bring it home and summarize what we've discussed so far. So what do we know based on my conversation with you, Dr. Madsen's conversation with you, right? More plaque, more worse, right? The more plaque you have, the more at risk you are. We see this with calcium scoring, and more importantly, we see this now with quantitative plaque analysis. What do we know from DECIDE? This is really the first time we're now seeing how quantitative plaque analysis can be integrated into clinical practice and alters management. We see that providing the quantitative plaque analysis results in increasing changes in management. 50% of the time, just over 50% of the time, we had a change in management over and above the results of conventional CTA, right? So significant impact in terms of how we care for patients. And importantly, now we're seeing for the first time how staging plaque, right, providing these quantitative numbers allows us to stage disease and intensify therapy based on stage of disease. So as Dr. Taylor mentioned at the beginning, really moving now from a risk model to a disease model. So that's where we are with the current state. Of course, future state, right, where are we going? What we want to know is, do these changes in therapy actually improve outcomes? Well, that takes time and large numbers of patients. We're all anxiously awaiting results of prospective studies such as SCOT-HEART-2. Really exciting times. Almost on a weekly basis, we're seeing results coming out regarding how quantitative plaque analysis can impact management. And I'm really looking forward to a very dynamic discussion regarding the topics that we've discussed today. Thank you very much.
Thank you, Michael. That was so eloquent and really well delivered. Terrific information from the DECIDE Registry. So that concludes the presentations, but we'd like to now move for our 110 participants to open discussion. You can put your questions in the open Q&A, and I'll call them out and we'll discuss them together as a group. I will thank Kaylee Brandt. She gave us a few questions to think about, which regarded the use of quantitative coronary plaque analysis for monitoring response to therapy. Really a future look, but it's something which the technology enables, and it really moves us in the disease model to knowing if we're controlling the disease. So something which I sort of believe in, but I'll toss that question to Christian. Christian, with your deep background in AI-based analysis of images, how do you see the potential for not just using this to detect disease and stage it, but then to actually monitor it on an individual patient basis?
Well, that's an excellent question. I think that if we look into patients, there are different phenotypes, right? So you have patients that have a lot of plaque. The composition may vary, but also the placement of the plaque, the plaque must also vary. Maybe you have some plaques that has a constituent of both the high-risk plaque features. They have a high amount of low attenuation plaque. They cause a severe stenosis. You want to treat that perhaps by utilizing a stent, regardless of whether or not the FFRCT is abnormal or not. We've seen that from the PREVENT trial already. And then you have patients who have widespread non-calcified plaque, for example. And in those patients, it is key to prevent these plaques from progressing. So they will require an intensified medical therapy management. And perhaps, as you have also suggested here in the excellent talk by Dr. Michael, that perhaps we need to introduce PCSK9s to patients already at an early stage to prevent them from progressing to a stage where we have to intervene interventional to prevent an event.
Yeah, thanks, Christian. Really appreciate that. Michael, a quick question for you, and then we are getting some questions in the Q&A, which is great. The impact, coming back to DECIDE, Michael, the impact overall with 1 in 2 patients basically after a CT plaque analysis having a management change, and in the highest risk groups, those people with stage 3, stage 4 atherosclerosis in the disease model, up to 2 in 3 having changes in management. How does that number is, I think, strikingly impactful. Would you agree with that?
Yeah, thanks very much. What I think is so interesting about this is, it's really about a paradigm shift, right? As Dr. Mattson mentioned, when we look at this unique phenotype of patients with elevated plaque volumes and higher risk profiles, now it becomes, how do we bend the curve in those patients, right? So how do we get the ordering providers, referring providers to prescribe appropriate pharmacotherapy, and then how do we get patients to actually take that pharmacotherapy, that medical therapy? And the staging approach, I think, really helps simplify this concept. For those of us that do this for a living, I mean, we get it, right? But it's really, how do we spread that message out to other people, right? Spread it out to ordering providers, spread it out to patients. And the staging concept, I think people implicitly understand. And that really, I'm hoping this intensification of therapy based on higher stages hopefully will translate to improved outcomes over time. We certainly think that's it.
Yeah, thanks for the answer. Michael, there's a question in the Q&A about the DECIDE Registry and whether it suggested a role for aspirin, and it reminds me that DECIDE assessed what management changes clinicians made, but not necessarily their outcomes impact. Is that correct?
Absolutely, too early. So this is early data, 90-day data, but yeah, we're anxiously awaiting. Going to take large numbers of patients. Overall, DECIDE almost 20,000 patients. Again, we need these large numbers because the event rates, are lower, as we've seen in PROMISE and other, contemporary studies on CT.
Yeah, but I think to the question and the idea for the listeners is, once you stage disease, you then calibrate your treatment to the level of disease in this disease model. And Michael's correct. Aspirin could be a part of that strategy for a patient. But certainly aggressive lipid management. Our problem is less about the number of the drugs available, such as PCSK9 inhibitors, but it's about how often we apply them. And I think this optimal application is really the trick to going from, not just diagnosing, but also in management changes, but actually to outcome changes. There's a question here, and I'll give this one to Christian. This asks the question, is there data on lesion-specific correlation to OCT or IVUS? So lesion-specific correlation, it's the noise on CT being called non-calcified plaque by AI plaque analysis. And if we could maybe address those questions, this is about building confidence in the AI coronary plaque analysis and the IVUS correlation. Oh, Christian, I think you're on mute.
Oh, sorry. Well, we have seen the IVUS validation trials, right? So they are incredible. They show a really good agreement between what was found using the CT-derived plaque and the IVUS-derived plaque. So I think that is settled, that the two methods are very much in agreement with each other. So yeah, I would say that it is really well validated.
Yeah, terrific. And then also in this question, there's this idea about noise, and what I would say to the question about noise, and yeah, you need good quality imaging, and for instance, photon counting CT is the next step in high quality CT images to get the most reliable plaque analysis information. I would say to the questioner, though, that the development of AI-assisted coronary plaque analysis is iterative, and it's improving all the time. And in fact, HeartFlow has new algorithms being released that actually have increased accuracy, increased precision for border detection and the quantitative results. So you can expect, if you've had this questioner had early experience with the plaque tool, that's great. And I would say, keep giving your feedback, but the algorithms are iterative and improving all the time, really. And with the flow of data from 1,100 centers, this is going to be very, very active and fast. And Christian could probably tell us that the more data that feeds these AI models, the better they get.
Yeah, definitely. And like you said, and which is spot on, image quality is everything, right? Like we say at my institution, shit in, shit out, right? Because that's just the reality of things. So what you have to do is you have to look at your own images, and you have to just take a step back and say, okay, this is too bad. And then you have to put the patient back in the scanner, and you have to lower that heart rate a little more, and you have to do a rescan of the patient. You don't have to use, it's not supposed to be that you use the AI to provide you with the ability to make a decision based on bad image quality, because that's not the way it should be. You should have good image quality, and then the AI can help enhance your decision making and also provide you with a numerical amount of plaque, which I find to be really helpful. Because if we are describing a CT image set, you might have one CT cardiologist saying there's a lot of plaque, and an interpretation from another CT cardiologist looking at the same patient would be that's a moderate amount of plaque. How much is it? We don't know. Now with the plaque tool, we get a numerical number. It's much easier to categorize.
Terrific. Well, Christian, what's next for advanced DK? As congrats on this very recent presentation. And for all of our listeners today, this is information hot off the press from this summer, July and August. What's next in advanced DK?
In terms of advanced DK, I think that we will look into one more manuscript coming from the advanced DK. We have two, one which is in press currently, one which is undergoing the final revisions, and then we're going to aim for a third. And in the third paper, what I really want to look into is the amount of information that you can gain on top of calcium by performing the quantitative plaque analysis, because to me that is really key, because you need to get more information by quantifying your plaques than you could obtain by just performing a non-enhanced CT scan and get the calcium score. Otherwise, it would not be worth it. This is what we're seeing from the advanced DK data, and that's where we're heading with that. And then we are already, based on advanced DK, planning some randomized controlled trials, which will look into reconfirming some of the findings which we have seen from advanced DK, because as I said, it's an observational study cohort. So we need to confirm these data in an RCT setup, and that's what we're aiming to do.
Yeah, I think it's really important that you've demonstrated that coronary disease requires, for the symptomatic patient, requires both an assessment of physiology, that's FFR, but then this idea to fully manage a patient in a disease model, you've got to have plaque in it. You've got to know how much plaque, how much disease is there, and then match disease extent with therapeutic intensity. And I think that's the shift that we now are solidly in with a single tool that delivers all of that. And Michael, from the standpoint of DECIDE, obviously this is the first information from DECIDE, really important information showing just a high degree of management impact. And what's next in the DECIDE registry group?
Oh, let me count the ways. So there are multiple avenues coming forward, because there's multiple ways in which we looked at DECIDE. How does it impact patients who have stents? How does it impact patients who just are getting that information prospectively without the benefit of the difference between the baseline coronary CTA and then the additional plaque analysis? And a number of different factors, right? As Dr. Madsen mentioned, looking at further subgroups and seeking to understand. Now, importantly, these were all symptomatic patients, although, again, another subarm of DECIDE is asymptomatic patients, right? This screening cohort. And how does the plaque analysis inform us in that group? Because we know that symptomatic patients and asymptomatic patients may not necessarily have the same natural history.
Yeah, thanks so much. Let's see, moving on to other questions here. Yeah, Abraham Solomon asked a question about this vicious cycle of we're really in this risk-based model with things like the pooled cohort equation, the prevent equations, and now we've got these much better tools. It's the money question. I think we've got to move away from risk-based equations. This is my opinion, because we have much better tools that accurately and fully define disease, which then translates to risk and to management. Right now, using risk-based equations is largely just a guess. It's a population tool. And I think with these more refined tools available, it's really where we need to be turning our attention. So we appreciate everyone who's listening to this. Take that as a message and think about it and how you manage your patients and how you talk to your colleagues about the use of coronary CT, FFR CT when there's a need to establish physiology, but then adding in plaque assessment as a routine part of your management to know exactly what your patients have and then how to manage them. Let's see, I'm going to see other questions. Yeah, there's a question from Niels Peter about, do we know about low-dose statins to patients with intermediate plaque burden? And have we skipped the concept of maximizing LDL reduction by initially without AI-CPA? Yeah, Niels, I would agree with you. We could just say we know we've got the information we need, but the problem is that those risk-based tools just are too crude, and we're not doing it now. 4% of patients right now that are eligible in this country, in the US, and not deceiving the worldwide, that are eligible for PCSK9 inhibitors actually receive them. And so we're really underperforming on a prevention standpoint. And it's because we're not making a diagnosis. We're presenting patients with risk, and patients don't understand risk. And risk is often wrong. And so I think your point, I think, nails it. We've got the tools. We've got to figure out the right patients, which is why these tools like AI-assisted coronary plaque analysis are so important.
Can I mention one? So
Please.
I think it's a great comment, and I think it brings us to the other way in which we're considering using the AI plaque analysis, which is not for just identification of atherosclerosis and quantifying risk, but also potentially as a biomarker to assess treatment response over time, which I think is sort of what this question is getting at. In other words, we treat patients with statins. How do we know that we're actually delivering the biological result that we want? There was a nice paper from Australia just published in JAMA recently, looking at changes in plaque volume over time, stratified by patients who were either on just usual therapy or more intensive statin therapy. And you can see differences in plaque morphology, just like what Dr. Madsen mentioned with Paradigm. We see changes in that phenotype of plaque based on intensification of therapy, and potentially using that as a biomarker for treatment response to adjudicate whether or not patients are on appropriate therapy.
Yeah, thanks, Michael. Another question here regarding age and whether that should be a factor in how aggressively patients are managed. I think I'll give you my personal opinion as someone that does CT and also prevention. The analyses you've seen today, for example, those from fish and chips, are adjusted for age. And really it gets down to disease. And we're treating disease because disease extent is driving the risk. Atherosclerosis develops across long time horizons, and it's diminishing the amount of LDL exposure, for example, blood pressure optimization, diabetes optimization, that really matters. And so when you find disease, it's an imperative to do it now, I believe. The therapies are there, the therapies are safe. I think we really want to start to translate the imaging information to action on prevention, and to really ultimately be successful in the long term.
Yeah, and if I may add to that as well, because it's really important, as you highlight, to say you have an elderly patient, you can have one with and one without coronary artery disease. And I would agree, if we don't have any signs of coronary artery disease, would it make sense in a primary prevention concept to provide statins to that patient? Probably not, because disease develops over time. But as you say, if you have a patient who already has the disease, does it make sense then? And yes, it absolutely does, because we have seen data from several studies now suggesting that already within 3 to 6 months, we start to see this recompositioning of the plaques turning into more stable phenotypes. And it only requires one plaque rupture to cause an MI, and this may happen at any time point. So I would definitely say that if you have, even if you only have 5 years left to live, it's still worth putting that patient on statins so that you reduce their risk of having a plaque rupture and thus an MI. But they have to have the disease in order for it to be relevant.
Mm-hmm. Christian, we're reaching the end of the hour, and I want to thank everyone for joining. It's really been important, and I really hope that we've established our intentions with you, really informed your information, in bringing to you this really recent insights from AI-assisted coronary plaque analysis and its impact on prognosis and management. There is a question here just about the different platforms, Christian, that are available for AI-assisted coronary plaque analysis, and there are other platforms. And without having to get too in depth, I would just maybe ask you, what, as you think as a scientist in this field of AI-based work, what are the features of a good platform that you look for, and that you look for?
Well, first of all, if we go back just a few years and we look into how we did the plaque analysis back then, you had these semi-automated plaque tools where you had to go in and you had to open the CT scan, you had to, perform a lot of the work yourself, which was cumbersome. It took a long time. It was interesting for research purposes, but it would never ever be something you would implement in the clinic because who would have the time to do this? So with the implementation now with tools such as AI-CPA by HeartFlow, where you can just, look at the scan, you can push your button, you can get the FFRCT simultaneously with the plaque, you can look at how the two correlate, you can scroll down through the vessel. To me, that is the platform that we're looking for. Now it has become clinically relevant. I don't have to do the work to get the result. I can assess the result and I can change my patient management accordingly. So for me, that is the most important feature. And obviously also you have to have a tool which has been validated against the current golden standards. And a lot of the tools that are out there are still lacking in that regard. But I know that these data are available for the HeartFlow tool, which is why this is the tool that we have chosen to use at my institution.
Yeah, terrific. Thank you, Christian. Well, great. Well, let's give people the benefit of 8 minutes back to their day, which is always beneficial. We've learned a lot. I want to finish by thanking first our sponsor, HeartFlow and SCCT, for allowing us a platform to bring two excellent speakers to you today. Christian and Michael, thank you so very much. Eloquent and really impactful information. Thank you to you, everybody. Thank you, all our attendees. I hope you have a great day and hope to see you in the future. Thank you.